Just to show you the surface anatomy here. So this is the eyebrow. Okay. So this is the this. If you want to do a subbrow incision, would be from here. Would be from here to here. If you want to do a lead crease incision, would be here to here, and then you can extend a little bit, curve like this. Do we have a skin marker? Do you have a skin marker?
Skin marker?
Or if not, I'll just show you how I do it with the directly there. Okay. Okay. All right. Forceps. Okay. All right. So for subbrow incision, would be from you palpate on the orbital rim, but directly here to here. Okay. And for the lid crease incision, would be here, extending along the lid crease like this, and then curves outwards, horizontally, just lateral to the lateral canthus, and extends a little bit here more. And after general anesthesia, it's always important to check where exactly the lid crease is. Now this is cadaver, so it's difficult, but in patients where there's less wrinkles and there's the globe is full, then you can do it like this. During the surgery, you check where the lid crease is, and then this probably is the lid crease. Okay. All right. So do the incision. Okay, so this is skin incision. And then next you use scissors to develop the plane. You can have scissors. Matimum. Okay, this is okay. This is better. So always next use a curved scissors. In surgery I use a curved matimum. Okay, to develop the plane. So you see this is the orbital septum. Can you show it a little bit here? So you see the difference. This is the skin, and here is the orbital septum, which is yellowish. Okay, I hope you can see it outside. Okay, it's good. Okay. And especially if you want to remove the orbital rim like this, you have to extend the incision a little bit outwards. Okay. One of the mistakes that beginners make is that they do not extend the wound a bit lateral. Cosmetically, it's fine, so don't worry about that. Okay. And here is the orbital rim. Here. This is the orbital rim. This is bone. So you continue to go up to expose the rim here, while pushing the periorbiter down. Here is the periorbiter, the orbital septum. And then now you incise down to the level of the bone. You can use a dissector to palpate it. here. Okay. And then you use a knife to cut on here, or you use a monopolar. So cut right on to the oblong rim. Can you see it? Okay, so this is the oblong rim. This is demonstration, so I expose a little bit more. But usually I just expose from here to here is fine. And then you use a periosteal elevator to bluntly dissect the periorbita from the oblong rim. Okay. This step is very important. You want to keep the periorbita as intact as possible. Otherwise, the orbital fat, it will come out, and that can obscure your view, and also it can cause complications like ophthalmos afterwards. Okay. It's a very fresh cadaver. So this is the suture here, this zygomatic frontal suture here. Okay. And here is probably the lateral canthal ligament, which is, we can preserve it. It's not necessary to remove it. Okay, now we're here. We're at the periosteum. So you can put a scope a little bit here. Yep, and you can see that we're on the undersurface. Okay. Let's just cut a little bit here. Okay. Now I'll show you how I handle this oblong rim. You see the way that it curves in. Now one of the ways that you remove the oblong rim here. From here you remove the whole piece, or you can just shave it, flatten it. I'll show you how I shave it. Okay. Drill. With suction? Yeah, please. Is it possible? Or just to raise it a little bit. Just a little bit is fine. Yeah, okay. Oh, it's okay. It's okay. Just leave it. Just okay. It's okay. No, it's okay. It's okay. It's okay. It's okay. Yeah, it's okay. No, it's okay. Yeah. Suction. Drill. If a suction. Oh, okay. Yes, this one. More? More, higher. Suction. Maximum? Okay. Drill. Your foot pedal. Now the assistant, you need to protect the periorbiter a little bit like this. Okay. Yeah. Okay. So I just remove this rim here. Do you have another forceps or retractor? So you can help me to retract. Forceps, larger one. Oh yeah, that one. So, okay, the retractor. Okay. Can you help me? Can you help me to pull a little bit?
Yeah, just a minute.
Yeah. Okay, thank you. Perfect. Okay. So just remove this this rim here until it is flush with the inner side that is here. Irrigation. The suction is not working well. Oh. Okay. Yeah, irrigation. Okay.
Travel on outer.
Okay. Okay. And the drilling is enough, it's complete. So, okay, so show you the difference. Now, this is flattened, and you see it is flush now with the inner table. So the scope can park it here, like this. Okay? Otherwise, you can also remove the rim if you want, but sometimes it's not necessary. Okay. Now, I will go in. All right. This is okay. Dissector. dissector here. Okay, all right. By the way, is this a videotaped? Is this videotaped? Can you put on tape? All right. Okay. Okay. All right. Now go in to show through the orbit to show the SOF. You see that the orbital fat is here, so it's a little bit coming out. It's always the case for cadavers. It's very fragile. So if that's the case during surgery as well, you find an area that is still intact, and you dissect from there. So to preserve as much as possible the integrity of the periorbiter. Yeah. Can you help me to hold this? No, this one. Yeah. Okay. So always do this dissection under the endoscope. You just go back up again and find the SOF. There's always a little bit of small artery here. It's called the Hurdles foramen, as it can be removed. This is a small artery here. Is this head injected or not? No? Okay. All right. Yep. Okay. Somehow there is a weak point here. There's a fracture. You see the way how it turns vertical? So this is near the SOF. So my advice is it takes time to do the initial dissection. It will be very helpful afterwards. It's a bit weird. There's the bone is not normal here. Okay, so this is the SOF here. This is the upper roof. There's something going on here. This is a greater wing of sphenoid. Okay, this is the SOF. And we go down. Here is the IOF. There's a small artery. You're going to cut it. Okay, now we put in the retractor, and then it will show you better. Okay, like this. Thank you. Okay, so this is the, I think this is the SOF here. Need to adjust a little bit better. Okay, like this. All right. Yes, so this is the SOF. Okay, and here is the orbital roof. We can use the navigation to show it, show the anatomy to you. Can you show the navigation on the monitor as well? On the screen? The retractor needs to take out a little bit. All right, okay. Yep, so this is the SOF. Yeah, can you show the bone window? Bone window and enlarge it. Okay, while they're adjusting it, I'll continue to show the anatomy. Anatomy still is most important.
Yes, sir.
Okay.
The bone window.
All right, okay. I just want to check what this is. This is a little fracture here. There's some interference. All right. Okay. Uh-huh. So this cadaver is there's some pre-existing anterior cranial base fracture or something is abnormal here. And you can see it from this scan. Yeah. There's a defect there. All right. All right. Okay. All right. Okay, just hold it here. All right, next I'll start the drilling. So drill, first of all, towards the temperatus as mentioned. So here would be the temperatus. Here, just drill here.
You can change. You want to change it?
You can use this one first, it's faster. Yeah, help with the irrigation. Right. Irrigation. Irrigation.
So that's the chopstick technique he's using.
Yep.
The camera. He's holding the scope and touching on hand. He's holding the scope and
Irrigation.
the
Yeah, can you? I think you can show it and how I hold it.
Can you make that one bigger?
Yeah,
bigger.
here.
VIP bigger.
ഇത് മാറ്റി ഇത് വേണ്ട ഈ സാധനം മാറ്റി അത് വലുതാക്കി ഈ സ്ക്രീൻ മാറ്റി ആ സ്ക്രീൻ ഒന്ന് ഒരു മിനിറ്റ് വലുതായി കാണിക്കുള്ളൂ. There it is. You can see that the top and the left hand at 11 o'clock position.
Irrigation.
Yes. Okay. Now we can reverse it back.
So you can use a cutting burr for the initial phase, it's faster. But make sure you do not catch onto the irrigate. Okay, good. Make sure you do not catch onto the periorbita. Irrigation. This is the muscle, the temperatus. Irrigation. So it's actually just like a craniotomy. Craniotomy through an orbitotomy. So you see the muscle first here. So this is the first step. You show the exposed to the temperatus. Okay, and then I use a dissector. So you can push the temperatus here. This is muscle. Okay, so this is outside the craniofossa area. So this is the area that we want to drill, the greater sphenoid. Why do we need to drill out to the temporalis? Is that we create more space, more room inside, more surgical freedom. irrigation. So during the bone drilling, there would be sometimes quite a lot of bleeding from the bone marrow. So you can use bone wax or just irrigation or flow seal to stop the bleeding. Especially quite a profuse bleeding if there is, for example, a sphenoorbital That would be the blood supply. Okay. Can you help to hold the scope? Okay. Now I switch to a two-hand technique. Okay. You stand there. Like this. Okay. Right, you hold it against the bone here. Yep, okay. Oops. So you see, sometimes it's difficult for the assistant to hold the scope. That's why I use the chopstick technique. It's okay. All right, yeah, please. Okay. Yep. Okay. Just to show you a different way that we can do with so I can do it with a chopsticks, I can do it with a traditional two-hand. Can you hold the retractor, please? Thank you. Okay. Drew? So this is a greater wing of sphenoid. Try to enlarge it drill until you reach the middle fossa dura. Okay. It's important to drill as wide as possible. Instead of digging a hole inside, you want to drill as wide as possible. especially we want to reach to the middle fossa base, which is here. In surgery, from now on, I will switch to a diamond burr. I don't think we have a lot of time today, so I push a little bit. I use continue with the cutting. Again, I'm pushing lateral. This is the temporalis. Okay.
Excuse me for your kind attention. Tea is being served outside the hall. We have 2 counters, one near the front door and one near the back door. It will be served till about 10:45. Thank you.
Go up a bit. Here. Here. Yeah. I think we're almost reaching the dura. Here is the middle fossa floor. Okay. Here. Right. Okay. Yep. Do you have a larger retractor? Do you have a larger malleable retractor? Bigger? Bigger? Can you hold this? Can you hold, please? Hold, yes. Okay. Or drill here? Okay.
You can discard it.
Okay, this is a dura. Okay. I'll show you with the navigation to see where we are. So I hope you can see it outside. This is the temperatus. This is the dura. Okay. Okay. From the navigation, you show the navigation.
Switch to camera.
It's the navigation camera.
I'll show you which level we are. So this is, okay. So this is where we are. All right, it's fine. Okay. Then I use kerosene.
Endoscopy.
1. I'll start with the 1.
Oh, the endoscopy.
This one. Okay. Okay. And from this onwards, I always use the kerosene. Okay. Okay, I can hold the scope. Thank you. Thanks a lot. You don't have to drill all the way using the drill, but then you can use the kerosene. It's faster, and it's actually safe as well. So I push. You see how I do it? I push the dura away, and then remove the bone. Okay. I use a dissector to push. Okay. Now this is the floor of the middle fossa, and here is the greater machine. Okay, here. Right, yep, like this. Kerosene. Do you have a 2 millimeter large one? So wide exposure is important for the middle fossa dura. Now I'm flush with the base here. Okay, it's good. So I can show you here soon the V2 quite easily. Okay, I'll show you the V2 first. So here I lift. I do a okay. So this is a middle fossa floor. Here is the V2. It's going down. You see how I do the interdural peeling? I think I need to remove more of this bone first, okay. I continue to use the kerosene. Do you have a 30-degree scope as well? Okay. Let's change the 30-degree scope. Dissector, a curved dissector. You have a curved. Okay, yep. Now I switch to a 30-degree scope. I'm pointing down. Okay, I'll remove more bone first. Okay, let's try. No, it doesn't fit. This one. Okay, like this, right? Somehow the middle fossa floor, just hold, please. The greater wing of sphinx is very thin. I'm not sure why in this cadaver. See, just breaks. Usually it's not like this. You need to drill and use a kerosene, quite a lot of bone work. Okay. Okay, we're approaching the medial bit. This is the sagittal crest. Okay, can you hold? Okay. Oops. This is a small hole in the dura. A 1 millimeter, 1 millimeter kerosene. Ah, okay. Yep. So I'm removing more bone towards the superior aspect. This would be near the lesser wing of sphenoid. This is the lesser wing of sphenoid. We're near the SOF. It's a very thin piece of bone here. I think this is the SOF. So now we're looking up, which I mentioned is very important for the orientation. So here would be the frontal dura. Okay, the sector. This one is fine. Here is the frontal dura. Here. Or probably for this very interesting case, let's take a look at the navigation. It can be the frontal sinus. Yep, this is the frontal sinus. It's a huge frontal sinus, unusual. That's why all the bone here is very pneumatized, and it's very thin. Okay, so this is the frontal sinus. Okay, I think that's the frontal mucosa. Yep, it's a frontal sinus. Right, okay. Unusual. Which means we need to remove more of this bone here. This is a 2 millimeter? Yeah.
Just 2.
Okay. It's huge. The frontal sinus is huge.
So, what do you do if the frontal sinus opens up during your surgery?
You mean the frontal sinus?
It opens up accidentally during your surgical exposure.
Yeah, so now first of course, I need to study the scan before the surgery. Try to avoid opening the frontal sinus. If it's opened, keep the mucosa like this. Okay, do not open the mucosa. So you use a dissector to strip it, push. Sorry, the scope is not working well. But this is the how you push. Yes, you push it. Keep it as intact as possible. And then just to remove here. And then afterwards you put in fat. Yep. Okay.
This side also.
I think 30 degrees. Yeah. A bit dirty.
Take it at dry goes now.
That's the lens. Yep. How much time do I have? Okay.
How much do you want?
Well, just let me know. I can stop anytime. And then there's an online lecture, right?
But let us see the structures first and then.
Yeah. Okay. Sure. Okay, now we go medial and remove the sagittal crest. Okay, here, suction. Dissector. Yes, that's a sagittal crest. Okay, just hold it. Pituitary. You have a small one? Okay, perfect. Okay, hold. Okay, so this is a sagittal crest. You see this is the middle fossa floor. And here is the sagittal crest, so up would be the mandible orbital bend. I will show you the MOB.
So sagittal crest is your landmark.
Yes, the MOB is a very important landmark. It is the lateral part of the SOF. Okay, still some way to go. You retract, please. Okay. You have the sector. Oops. Kerosene. Usually I use more drill in the surgery. But I think now with the kerosene, it's working faster. Okay. You hold this. Right. Yep. They have a curved dissector. No, it will poke inside. Okay. No, the other one that I just used, curved. Yep, okay. Okay, kerosene. The dura is very, very, very fragile here. Yes. Very thin. The dissector. Here is the MOB, this one, okay? And this would be the level of the, no, this is the level of the SOF. Kerosene. Usually I do it much faster, but the problem is the dura is very thin here. You have 1 millimeter? Okay, the most medial part of the dura, we have to keep it intact. Otherwise, it's not possible to do the interdural dissection. Okay. Good. Good. Okay, can you hold? You see how the orbit Okay, it connects with the dura. Here is where the MOB. So here is the orbit. Here is the dura. And here is MOB. It's too thin. Now there's also a way how to show where the MOB is, or make sure this is as well. Is that you push the dura gently, and then this will move. Okay, usually. This is one of the most important steps during the exposure. Okay, this is the MOB. Okay. All right. Can you hold this?
Do you always use a 30-degree for this, or you do 0 degree?
Sorry?
Do you always use a 30-degree scope, or you do the 0 degree in this particular?
I like to use a 30-degree scope. Okay. So I can see much better. So this is the frontal sinus. It is very unusual to have this huge pneumatized frontal sinus. It is very unusual. Okay, but we're here. Okay. Okay, now I'm going to show you the MOB and to cut the MOB. Let's switch back to the 0 degree. I think the 0 degree scope is, the optics is better. Now it's better. Okay. All right, hold.
Elastic sheets.
Do you have it? Oh, okay, it's better. Here.
How much do you need?
This size, that's okay.
Do you want to try a 45 scope? Because I think the 30 is slightly, they're going to take another scope.
Mm-hmm.
There's some problem with the clarity.
Yeah, there's some problem with 30 degree. I changed the 0. I changed the 0. Yeah. Yeah, some problem with the scope. Okay, forceps. Now it's better. Right, it's okay.
You could tell them this elastic.
Okay, so this is a elastic sheet that I put in. It's helpful, especially if the periorbiter is opened. Okay. Okay, and then you retract on this elastic sheet as well. So it holds the fat back, basically. All right, can you hold? Please, hold. Okay, I'll use a drill. You have a diamond burr. Here is a sagittal crest. Drill.
Metronics?
Do you have a large kerosene?
Back.
Pituitaronja? Do you have a pituitaronja? Large one.
Large?
Yeah, yeah. We're waiting for the drill. So I try to remove more bone here first. Okay. Ah, okay. Now this is the drill that I like to, more irrigation. More irrigation. More irrigation, more. Okay. I like this drill because it is the moving part is very small, so it won't catch the fat. Okay. Do you have a cutting burr?
You need to put the tongue in first.
Do you drill much lower? Okay, can you hold?
Speed of the hello, 25,000. Little bit deeper.
Drill may break.
Little bit may break. No, 75,000 after.
Ah, okay. The cutting, this is cutting.
This cutting. You won't match the cutting. Yeah.
The match cutting is okay.
You got a 30-degree new screw. You
Okay.
got a 30-degree new screw.
30 degree? It's okay. Ah, okay. Irrigation? Okay. Suction is blocked. Suction is blocked. Okay. Okay, here. Hold. Drill. Irrigation. Okay. Okay. Now what I'm doing is I extend inferiorly because just now I was misled by the frontal sinus. So I made the little mistake that I mentioned that I drew to superior. All right? So this is the MOB. Here is the middle fossa. That was the anterior fossa. Kerosene. But it's okay for the... anyway, we still need to remove more of the frontal bone. So here is the middle fossa dura. Okay. Okay. So we need to, if we want to remove the meningioma, then we need to have this very wide exposure. So here's the greater wing of sphenoid. This was the lesser wing of the sphenoid that was drilled. Here is the SOF. Here is the lesser wing of lesser wing. So now I'm removing the greater wing here. Okay. This is the MOB. Orbit, SOF, MOB. Okay. Exposing the whole MOB here. Here is the sagittal crest. Okay. And I remove the floor. Remove the flush. Oops, sorry. Okay. Now we should able to see the V2. Freer. The this one, the dissector. This one is fine. If for a curved one. Let's see. I'm elevating the metafossa dura from the floor. Okay. Okay. Ah, okay. All right. Thank you. Okay, there's a little bit of a crest here that is in front of the V2. So we can use the navigation again to show. Navigation. You can switch the camera to the navigation.
Show navigation.
Some interference. Okay, so navigation can be helpful, but sometimes during the operation as well, it's depends really. Okay, let's cut the MOB first. Scissors or the knife. Okay. Yes. I usually use a retractable. You have a retractable, but this should work. Okay, I'll cut. There may be a small artery there that runs into the MOB, so you can cauterize that. Okay, let's cut. Okay, hold. Now this is the sagittal crest. So actually it can be very thin, that it can be fractured. So all you need to do is just to use a pituitary rhondra to remove it. Okay. Pituitary rhondra. Small. Now this is removed, and then we see the anterior part of the cavernous sinus, which is here. Okay, need a better retraction. Okay. Okay, and hold. Oops. Hold. Yes. I will drill this part, and this should be the final part of the drilling. And afterwards, I'll show the content of the cavity sinus. With a diamond. Okay, hold. Hold, yes, okay. Dissector. have a pituitary rhongia. Now, there are several ways to remove the sagittal crest. You can drill, or you can use a large pituitary rhongia like this. You hold the base, just like how you do a clinodectomy. You eggshell it, and then remove the base, and then the tip will go out. Okay, see? So this is it's just like the tip of the sphenoid. Okay, go a little bit deeper. Right here. Yep. Hold. Okay.
Can make this, can I have 30 minutes break? We'll remove the bone
Yeah.
before we peel the cavernous, and then we'll come back and show that. So
Yeah.
I have lecture in the meantime.
All right. So I stop now.
No,
Or
we can continue. We can remove the bone,
okay.
right?
Yep.
We'll have an online lecture.
Yeah. Sure.
Then we'll do the peeling after the lecture.
Yeah. Sure.
And the V1, V2, V3, everything will be done. After the bone removal, we'll take a short break for the online lecture and come back. So the dural dissection will be done only after the lecture, right? So, is Soprano ready?
Right. So this was the meningo-oblong band that we dissected. Right. So can you hold? Okay. So this is the middle fossa. Down. Okay. It's okay. No. Now this is the middle fossa floor. The brain is coming out a little bit. Okay. Now this is the middle fossa floor. And when we look more medially here, we're starting to see the lateral wall of the cavernous sinus. Now this is the cavernous sinus wall. And you need to peel. There is some ice here, I think. It's very hot here. Okay. Okay. Yes, okay. All right, so this is the V1. This is the V1. This is the V2. This is the V2. V3 should be here. Okay. So what you need to do is to elevate the temporal dura until you see the Mecco's cave. Usually I have a curved dissector, but this is okay. I don't think you have it here, the curved dissector. There's a lot of ice here. Yeah. I'll just leave that part behind first. I'll show you the cavernous sinus. All right. Yeah. I'll show you a little bit more of the anatomy first, and then you can put hot water. Right. Okay, anyways, this is the V. This is the V1, V2. Okay. I'll just do a little bit more demonstration, and then we'll wait for the hot water to work. Okay, can you hold? Can you hold? Hold? Yes, please. Thank you. Thank you. So you see, this is how the V1 goes into the SOF. Here's the V2 go down. Here's the fourth. This one is the fourth. This is the fourth, all right? And so posterior to that, here would be the Parkinson's triangle. Now here is the third. V1, fourth, and here is the third nerve, the oculomotor. And when I go switch a little bit up here, I'll show you this, and I'll switch my lecture and then put some hot water. So that's the approach to the cavernous sinus wall. This is as far as I can get with this a little bit of limitation here, the specimen. So I switch up. Now, another application we'll show you in my lecture is that you can do optic canal decompression. So here is the frontal dura. I removed part of it, and here is fossa floor. So now we're on top. Here's the orbit. We're above the orbit. This, in the center of the screen, this is the posterior ethmoid artery. Here, this is the optic canal. And therefore, this is the ACP. This is the ACP. And here will be the third nerve. And this one is the anterior ethmoid artery. This is the anterior ethmoid. Posterior ethmoid. Here is the optic canal. Okay, can you hold this? I think it's okay. Now I will do the anterior clinodectomy here first, okay, and then wash, and then we'll do the cavernous transplant later. Just demonstrate how you do it. Now, since the lesser wing of sphenoid has been removed partly, then it's easier. So to lift up the frontal dura, and here is the ACP. For orbital fractures, you can do an optic canal decompression in this way. Okay, now this is the optic. Okay, this is the optic canal. All right, we can have a diamond burr. Sorry?
Some dirt on the scoop.
Yeah, it's okay. So first of all, you remove the lesser wing, superior to the optic. So the first step is to decompress the optic canal from medial to lateral, from here to here, because the lateral side would be the anterior clinoid, and the optic struct would be just behind. Try not to tract on the optic nerve, but you can lift up the frontal dura. Usually for cadaveric dissection courses, this would take 1 day actually. So I'm trying to squeeze everything in the morning. Okay, so you see the posterior part of the optic canal. So this is the anterior part of the optic canal. So this is the medial part of the optic canal. So remove it. Here, hold. Can you hold? Yep. Now usually during surgery I stop here, the medial side, because I already see the ethmoid air cell. So just for demonstration purpose, again, not to do it during the surgery, I will open the ethmoid. Okay, see the ethmoid here? I'll just open it. Here is the ethmoid sinus. So this is how you do it through the endonasal for the optic canal decompression here. No. This is the ethmoid sinus from the nose, okay? You have the curved instrument that I can probe it through. Okay. A hook, yes, a hook. All right. So you see how it is. Much better, actually. You see the degree of decompression for the optic canal from above, from transorbital, is much wider than endonasal. Endonasal, you can never reach the top, or nor the lateral side. So here, we're inside the ethmoid sinus. Okay? Well, again, during the surgery, if indeed you find this, then you put in a fat. I will remove here as well. Yes. So here would be the medial side. Here's the lateral side, and here is the anterior clinoid process. Okay. I will remove the anterior clinoid process. Here. Okay. Okay. Now, by removing the anterior clinoid process, of course, I need to unroof the optic canal first. And then to X-shout it, like what we do for transcranial. The difference is that the angle is more along the axis of the anterior clinoid when for transorbital when compared to transcranial. This would be very helpful for cases like clinoidal meningiomas. So X-shout it inside. I think we are almost there. Okay. All right. Can I have a dissector? Now we're in the tip of the anterior clinoid. Okay, dissector. Yeah, dissector is smaller, right? So this is the tip of the anterior clinoid. Okay. This is how it goes in. Okay, suction. Need to drill a little bit more. This would be the optic struct. So it's connecting the anterior clinoid process with the sphenoid bone. Dissector. Small. Suction. The carotid is you'll be seeing it right after removal of the anterior clinoid. So the way to protect it is actually the same as what we do it for transcranial. We X out it. We do not rock it. And during the operation, I also use the Doppler. Yes, this is the carotid. This is the carotid, exactly. So this is the remaining tip of the anterior clinoid. I'll use a dissector. Hi. Hello. So remove the last bit of the anterior clinoid. Or sometimes actually you can leave it behind if it doesn't go in your way. Anterior canalidectomy doesn't mean that you need to remove everything during surgery. And there would be some venous bleeding. I always use a flow seal or Surgiflow if you want. Here's the tip. They have a small pituitary, small pituitary rhongia. Small, okay. Clean. Usually we need a smaller pituitary rhongia. I don't know if we have it. This is a bit too big for this. But you can see the tip here. Ah, this is better. Right. I'll clean it. Okay, let me show you the tip of the clinoid. Okay, it's a very small bit left. So this is the tip of the clinoid process, and the anterior canalidectomy is done. So here is the, thank you. So here is the optic. Here is the carotid. Between the optic and the carotid, here's the optic struct. Here, okay? And beneath that, this is the third nerve. Here is the third nerve. All right, okay. I'll stop here. Okay. I just want to show you the lateral wall of the cavernous sinus. Now, of course, about the lateral wall of cavernous sinus or the lateral compartment, there are different ways to do it, including like endonasal extended approach, was demonstrated as well in the lecture just now. But then you see that the risk involved, and by mobilizing the carotid, there are intrinsic risks. So with this, we're able to reach the cavernous sinus lateral compartment without injuring or risking the injury of the carotid by no need to disturbing the ligament or so. All right, so again, this is the middle fossa dura. This is the V2. This is V2. This is V1. This is V1. And then okay, go back a little bit. Okay, can you hold? Yeah, I'll hold it here. You see this triangular structure here? This is the maxillary struct. Between V1 and V2, this is the maxillary struct. And if we remove, okay. Can you hold this? Okay. There was a small hook. I'll show with the hook. Ah, okay. All right. This is V1. This is V2. This is V2. And this is the maxillary tract.
Okay, okay, okay.
This is the maxillary tract
Okay.
between V1 and V2.
Yeah.
So if we drill here,
Yeah.
we'll be entering into the sphenoid sinus here. Okay?
Yeah.
So here's one of the ways to enter into the nose, meaning enter in the sphenoid sinus with the biportal.
That is actually the anteromedial triangle you are.
Yes.
Yeah, yeah.
All right.
This hole is the anteromedial triangle.
So and this between the V1 and V2 here, we can open it up here and we are able to reach into the cavernous sinus. So open here.
Can you show third nerve there in the lateral wall? Third nerve.
Okay.
Third
V1,
nerve.
V2. Still have some ice here. This is the fourth.
Yeah.
This is the fourth nerve.
Yeah. A lot of ice there.
Yes. Yes. And here is the third nerve.
Third nerve. Where exactly can we see the entry into the interdural space there?
Yes, we need to go more posterior.
That is the area where it enters.
Okay, just hold on. Okay. So I will. Okay, V1, fourth, third. I'll remove this part of the ligament. Scissors.
So anterior genu of carotid will be just medial to this entry area.
Sorry?
Anterior genu
Yes.
of carotid will be just medial to the entry of.
Yes, I'll show you. Okay, so this was the ACP
Okay.
that we drilled. All right, this is the optic nerve.
Now you are tracing third nerve posteriorly. Now you are tracing third nerve posteriorly.
Yes. All right, I need a dissector. Okay, I'm tracing posterior. So this is the whole course of the fourth.
Yeah. Oh, bleeding.
There's bleeding. Scissors.
That is the superior wall of cavernous sinus. That is the area of. Is that the area of superior wall?
Of the.
Cavernous sinus.
Yes, this is the area of the cavernous. Yes, exactly. So there is some bleeding, I guess. It's from the clot from the cavernous sinus.
But it looks very fresh.
Yep. Okay. The dissector. Not the hook. Not the hook.
fourth nerve has got a most posterior origin than entry into the cavernous sinus than the third nerve.
Yes, yes.
So
So
you're-
see the anatomy here. So the relationship would be, again, this is the V1, the fourth. This is the oculomotor.
Yeah.
And I think that's almost the most posterior part that I can reach. Okay.
Yes.
Okay. I'll clean the lens a little bit. And now I'll show you the relationship. Okay. Okay, this is nice. Okay, so this is fourth, V1. Now this is between fourth and V1 is Parkinson's triangle.
Yeah.
But this is very tight space. So we do not open here. Instead, we open more posteriorly, which the space is larger. Here.
So
See the space here.
You're opening infratrochlear triangle.
Yes,
That's
this is the
triangle.
Parkinson's triangle. Here. This is the Parkinson's
Okay.
triangle, all right? So we open here.
Yeah.
We open along the superior border of the V1. So this is how we identify during the surgery. Okay. And we should be able to see the 6, which is parallel to the V1. Okay, open all along here. Okay. And here would be the oculomotor nerve. And I'll open between this one as well. The third nerve and the fourth. There you can see that it's a much narrower space between the third and the fourth.
So if you do a dissection anteriorly, it can injure the nerve because of this close.
Yes, yes. So it's not recommended. So what I would do is I use this angle here, or I use this angle. Okay, you see the two angles. One is more posterior, one is more anterior.
Yeah.
These would be the two safe triangles to enter.
That's the anteromedial triangle.
Yes. Okay. Ah, okay. This is the instrument that I use for opening the medial cavernous sinus wall as well.
What is that instrument called?
It's
Yeah,
a,
very
I
good.
guess it's a feathered blade.
Is there any name for that instrument?
It's a feathered blade, is it?
Feather.
Yeah, it's a company, I think it's created by a company from China.
Yeah.
Okay.
Oh, now carotid is.
Here is the carotid artery. Okay. Now we're inside the cavernous sinus.
Which part of the carotid is now visible?
Here is the carotid artery.
Is it the posterior vertical?
Sorry?
Is it the posterior vertical?
It's a vertical, yes. Let's see. Okay. Now this is the inferior compartment of the cavernous sinus. Anterior and inferior. And when we go up here, here would be the more superior part. And from this, we would be able to see the sixth nerve, the abducens nerve. But there's a lot of clot inside from the cavernous sinus. Oh, it's very fresh. It's like injection of flow seal afterwards. Okay. I'll try to show you the sixth nerve. Not this one. Hook. All right. Okay, now this is also the carotid artery here. So this is the carotid from between V1 and V2, and here is the carotid between the fourth and the V1. And here would be the anterior genu over this area. Here would be the anterior genu. I need to open a little bit more anterior. Okay. And now I'm trying to show you the sixth nerve, which should be this one. I think this is the infralateral trunk. You see how it connects to the carotid artery, and it goes to the lateral wall. This may be the infralateral trunk. Yes, I think this is the infralateral trunk. Yes, and this is the sixth nerve.
That is the sixth nerve.
This one is the sixth nerve.
Okay.
This is the infralateral trunk. I will cut the infralateral trunk. Okay. Scissors. We're going to show it with a suction first. I'll clean a little bit so you see better. Okay, so this is the infralateral trunk just coming out from the carotid. Okay. Small hook. No, the one that I just used. This one? Okay. Oops.
So now you are seeing the posterior compartment, isn't it?
Here, yes, it's the posterior compartment. Here.
So when
Here
we
would be the anterior compartment.
yeah.
All right. And here's the posterior compartment. This is the sixth nerve. I will show the Toretto's canal and the Grubus ligament.
So you may be able to see the Doral's canal there.
Yes.
Is it possible?
Yes. But with the eyes, I'm not sure. Let's find out.
Maybe Gubert's.
Suction.
അതിൻ്റെ സ്ട്രക്ചർ അത് maybe the bone, petrosal process or clival bone.
So this ligament, see this is a ligament.
Goobers.
This is a Gruber's ligament. This one
Yeah.
is a Gruber's ligament.
Yeah.
That is a roof of the Dorelos canal.
Yeah. Actually, in endonasal approach, we will see it's on the other side.
You mean endonasal?
If you look for the Goobers ligament, it is on the other side. It is
Yes,
not.
yes, from the other side. So this is the transorbital root. When you see this is a Gruber's ligament.
Okay.
Okay, this is
So,
the Gruber's ligament.
so there may be somewhere near petrosal apex.
Yes. Here on the lateral side, it will connect to the petrous apex. So here is the Dorelos canal.
Okay. On 12 o'clock is the dorsum cella region.
Yes. Here.
Is that the bone in the depth, that area?
Which area?
Your dissector is that area.
Let's take a look with the navigation to answer the question. And I think, can you switch the camera to show the navigation? It's always good to have a navigation set up for demonstration. Is it okay? Okay. All right. Can you magnify? Okay, more. Yep, okay. With the brain, I guess with the brain is better.
It may be some ice. Frozen.
Okay. So this is the posterior part of the Dorelos canal.
Okay.
Okay, this is Dorelos, and just in front of it will be the brainstem, all right?
Yeah.
And lateral to that will be the petrous apex. Okay. It's very nice navigation. Yeah, so basically that's all for the anatomy for the cavernous sinus. Okay, again, fourth, third, V1, V2, and here is the anterior genu. I will lift it up and show you the anterior part of the cavernous sinus. Okay, this is the anterior part of the cavernous sinus. Okay, and this was the anterior clinoid. Okay, we still have the tip here. It's good. I kept it. So you see the tip of the ACP. It's here.
Okay.
All right. So I can remove it. Forceps, pituitary and everything.
That area may be the carotid oculomotor membrane region. That
Yes. And what I want to show you is that after I open this, is a ventral clinoid space. So this is a clinoid process, all right?
yeah.
All right, so this is the third nerve. This was the clinoid. This is the optic struct, optic nerve, carotid.
Yeah.
And this area, it is the ventral clinoid space,
Okay.
all right? So it is important for the invasive pituitary tumors.
Yes.
Sometimes it surrounds the whole carotid at the clinoid region. and it erodes the clinoid process. And here is the area where the tumor can get into. It is, I would say, is almost not possible to remove the ventral clinoid space tumor from endonasal, because you need to go through the optic struct, which is not possible unless you have a lot of retraction of the optic nerve. And this space is usually very, very narrow.
Is the ventral clinoid space and dorsal clinoid space are connected?
They are connected,
Is
but
there
this is the ventral part.
Okay.
The dorsal clinoid space, you can do it from the endonasal.
Are they connected?
They're connected, but they're divided by the optic struct. Okay?
Okay.
They're divided by the optic struct. So it's always, is a lot of times is mentioned about the dorsal clinoid space. The ventral clinoid space is also important here. So our group now is working on this area. We think that transorbital route is advantageous to approach here. You see, it's not very difficult. You do the interdural peeling, third nerve, remove the ACP, and here's the optic. And then this is the tumor that you will see. All right? This is the membrane that surrounds the oculomotor nerve. I opened it. So this is the clinoidal carotid artery.
Okay. That may be the proximal ring region.
Here is optic struct, so this is the clinoidal ICA.
Okay.
Okay, this is the clinoidal ICA.
And same, carotid column and proximal ring.
So this is the clinoidal ICA. This is the this is medial, already medial to the carotid. All right.
Medial side it is called a carotid clinoid ligament.
And this is
that is the exit area through the dorsal distal ring.
it will turn. It will turn laterally
Yeah.
to the to here between V2 and V3. Become the petrous carotid. All right. Here is the cavernous carotid, cavernous ICA, and it will go from here. This area would be the would be here. Would be the petrous carotid. Okay. Last thing I want to show you is the Macros cave.
Yes.
Freya. Dissector. Dissector. No, this one. No, this one. This one. Okay. Okay, this is V2, and I think this is V3. Okay, this is Macros cave. This is trigeminal nerve.
Okay.
Here's the fourth. V1. Okay, now you see the three branches of the trigeminal nerve. The second branch. This is the V3. By going laterally, that would be the petrous apex.
Then you are going into Kawasa triangle.
Yeah, this is the Kawase triangle. But to be honest, I think this is just for anatomical demonstration. I would not remove a Kawase triangle from this area. It just means it's possible, but I won't do it. I don't think it's the best approach.
For your kind attention, the lunch counter will close by 2:30. If anyone has not had lunch, you may please proceed to the floor below.
Dissector. Just showing you, here is the Kawase triangle. This is the petrous apex. Okay, so this is the Kawase.
Yes.
This is the petrous apex. Okay, but it's to be honest, it's not very practical to do for example, a petroclivomeningeoma here. The angle would be better if you go from the endonasal route, if you want an endoscopic approach. Or of course, a traditional Kawase, or using endoscopic Kawase is fine as well. Okay. Okay, last thing, between the fourth nerve and the trigeminal porus, trigeminus, that would be the tentorium. And you can enter into the posterior fossa with that approach. This one. Okay, all right, okay. Okay, fourth nerve is here. Okay, you see here? Here's the tentorium.
Tentorium, yeah.
Here's the tentorium.
That is the fourth nerve.
Fourth is superior is here. Fourth is here.
Oh, well, that is the fourth nerve.
Fourth is displayed superiorly. Right. So here is the tentorium that you can cut.
Is posterior to third. Third ever come. Tentorium kilometer triangle could common sense and roof could.
The one with the blade, yes. Okay. Okay. So this is where I will cut between the fourth and the V1. Here is the tentorium. Probably a knife is better. And the retractable knife? Okay. Now the first cut is parallel to the V1. The knife just goes back. All right. Okay. So this is the first cut. And the second cut would be just inferior to the fourth nerve. There would not be a lot of bleeding, just in case if you want to ask, because there is a, you can see that it's a single leaflet here. Okay, so the tentorium is cut. The one with the blade? This one? No. Yep. No, this is just a dissector. Okay, then I use this hook cutter. So now we're in the posterior fossa. Scissors. Down. Or this one is fine. Okay. Let's try. All right. So here's the brainstem. Let's have the navigation. I'll just show you where we are. Okay. So here we are in the brainstem, just in the anterior part of the pons. All right. So this is around the superior part of the pons, just anterior to the. So we see the SCA actually down there. Can you see? No. Can you switch the camera to show the navigation? Okay, okay, you can see now. All right, so this is the anterior pons. So it's a good approach if you have a cavernoma it can be approached in this area, if that, especially in the anterolateral part of the pons. All right.